Hello, I'm Dr. Vijay Balasubramanian, and I'm the Medical Director of the Valley Advanced Lung Diseases Institute. Welcome to this mini module titled Methamphetamine-Associated PAH, a case review. These are my credentials and my disclosures. Well, upon completion of this activity, one should be able to identify the clinical characteristics, diagnostic findings, and psychosocial comorbidities unique to patients with methamphetamine-associated PAH. Evaluate current therapeutic strategies and challenges in the management of methamphetamine-associated PAH, including the role of multidisciplinary care and medication adherence. And finally, design individualized, risk-stratified treatment plans for methamphetamine-associated PAH patients that integrate evidence-based therapies, addiction support, and psychosocial interventions. Well, let's start off with a case scenario. 45-year-old male, Caucasian male with a chief complaint of severe shortness of breath, chest pain, and anxiety. He has a substance abuse history of 15 years of methamphetamine use, with the last use of about 3 months ago. His background psychiatric history includes anxiety, depression, history of bipolar disorder, and some other background morbidities such as hypertension and hepatitis C. He's on medications, fluoxetine for depression, amlodipine for hypertension, and some PRN benzodiazepines for anxiety. No major surgeries, but his social history clearly includes the long-term methamphetamine use and the psychiatric comorbidities we spoke about. And he also has a background of unstable housing, which is a very common scenario in these group of patients, and difficulty with medical adherence. He has a family history of substance use disorder. Before we get back to the case, let's have a brief overview of the etiopathogenesis and the mechanisms involved in methamphetamine-associated PAH. There are four proposed mechanisms for this particular syndrome. So one is the alteration of 5-hydroxytryptamine signaling. The second one involves the oxidative stress pathway. And then third one is the reduced expression of the carboxyl esterase enzyme demonstrated by the Stanford colleagues, and dysregulation of vasoconstrictors and vasodilators and all of these mechanisms can lead to the vasoconstriction and proliferation, vascular remodeling, and subsequently pulmonary arterial hypertension. In 16 states, at least 1 in 100 adults reported meth use in the past year in 2018 to 2019. And the darker shades of green indicate higher prevalence of meth use. And as demonstrated in this cartoon, one can see that there are more darker shades in the western half of the United States, particularly in the Southwest. Now, let's talk about methamphetamine use in patients with and without cardiovascular disease. There are two graphs represented in this slide. The graph A represents the green curve, represents methamphetamine abusers without any cardiovascular comorbidity, and their Kaplan-Meier survival curve shows obviously a better curve, whereas the other two curves, which are the orange and the blue, represent methamphetamine-associated PAH and methamphetamine-associated cardiomyopathy, and both these groups had substantially lower survival curve, as well as, a poorer prognosis, so to speak. And that is reflected on graph B as well. So if one looks at the trends in deaths among all methamphetamine users between ages of 25 to 54 in the United States by sex, race, and ethnicity, then you can see that there is certainly a increased amount of deaths in pretty much all groups, but more distinctly visible in the non-Hispanic American Indian or Alaskan Native patients. And one can also see that men overall have a higher mortality that is indicated over in this slide. And then when it comes to women, and again, there is a predominance of increased trend towards mortality in the non-Hispanic American Indian and Alaskan Native patients. Okay. And they have been rising, but in women is not as much as the men overall. Comparison of methamphetamine-associated PAH patients and IPAH patients. This is just a comparison of the two phenotypes within WHO Group 1 pulmonary arterial hypertension patients. The methamphetamine cohort tends to be slightly younger in the mid-40s, whereas the IPAH cohort tends to be above 40s towards the 50s. The female predominance is still noted in this group, but since there might be a slight increase in male proportions as well, you might see a relatively lesser female predominance in the methamphetamine-associated PAH group. Predominance of white non-Hispanic patients, and then there is also a higher prevalence of functional class 3 and functional class 4, as these patients tend to present pretty late. And they have less favorable hemodynamic indicators with higher PVR, lower cardiac output, and stroke volume indices compared to the IPAH counterparts. Getting back to our patient, the patient had a normal blood pressure, systemic blood pressure, but the heart rate was slightly elevated at 100 beats per minute. Patient appeared restless, anxious, and mild tremors, which is a fairly common way methamphetamine patients tend to present in clinic. And exam, they revealed right heart strain signs like RV heave, accentuated P2, and no peripheral edema. Pulmonary exam was relatively unremarkable. Echocardiogram revealed right ventricular hypertrophy with an elevated right ventricular systolic pressure estimated at 65 millimeter mercury with moderate tricuspid regurgitation. Psychiatric evaluation revealed depression with active anxiety symptoms, and the urine drug screen was positive for methamphetamine. Some basic labs revealed a normal hemoglobin, slightly elevated bicarb, ANA was negative, and BNP was markedly elevated at 450. And then obviously the most important diagnostic test, which is the right heart catheterization, revealed elevated mean pulmonary arterial pressure at 50 with a wedge pressure of 8 millimeter mercury, a cardiac output of 4.2 liters per minute, which gives us a calculated PVR of 10 Woods units. So let's talk a little bit about the practical management of methamphetamine-associated PAH. There are no specific guidelines at this point. The treatment really follows your standard PAH protocols. Obviously, most of us use the risk-based therapy strategy based on the guidelines. So if the patient is considered low to intermediate risk, initial oral combination therapy with endothelin receptor antagonist and a PDE5 inhibitor is certainly indicated. Or if the patient is considered high risk, we can certainly consider triple combination therapy, including parenteral prostacyclin analogs, both IV and subcutaneous. Obviously, escalation strategies based on subsequent risk stratification, which can be either intermediate low risk or intermediate high risk. And then if the person is intermediate low risk, one can consider addition of a prostacyclin receptor agonist, or consider a switch from PDE5 to the soluble guanylate cyclase stimulators. And if they are intermediate high risk, addition of a parenteral prostacyclin analog may strongly need to be considered. Now, what are the challenges in this particular cohort? Especially, there are some concerns over IV therapy. There is always a risk of line misuse, and infections often limits its use. Data suggest IV drug use may not be a contraindication for pulmonary arterial hypertension therapy. Subcutaneous therapy may be a safer alternative in this group of patients. Some of the medication adherence barriers, which tends to be a major challenge in this cohort of patients, Methamphetamine use is linked to non-adherence in other chronic conditions such as HIV, for example. Now, some of the strategies one can use would include patient education, use of support networks, as well as telemedicine. Going back to our patient, now that we have a confirmed diagnosis of WHO Group 1 PAH, likely related to his methamphetamine abuse, patient was considered as a low risk person and was based on several of his characteristics and was commenced on a combination of PDE5 inhibitor and endothelin receptor antagonist. Patient was also referred to an addiction specialist, and then psychosocial support was provided through cognitive behavioral therapy and psychiatric follow-up. Now, the multidisciplinary care, especially social support, including family support and adherence monitoring, are absolutely crucial. So the comprehensive care and long-term management of these patients can be extremely important and multidisciplinary in nature. Meth abstinence and addiction support are very important. Abstinence may prevent progression and reduce complications like cardiomyopathy. Multidisciplinary care, such as involvement of addiction medicine specialists for structured intervention, as well as social workers to address support systems and rehabilitation access. So what about monitoring and transplant considerations? Drug testing programs like urine toxicology can help detect relapse early and guide intervention. And lung transplantation as an option. There are no absolute contraindications for abstinent meth-associated PAH patients. However, challenges can always include psychiatric comorbidities, financial barriers, and support system adequacy. Therefore, a multidisciplinary approach is absolutely essential to ensure successful long-term management and transplant eligibility in these patients. What about future directions in this cohort of patients? So the Exposed PAH study will hopefully provide some critical insights into methamphetamine-associated PAH prevalence and risk factors. And synergistic effects. Research suggests higher meth use in HIV-related PAH, highlighting the need to explore how meth and HIV interact to influence disease severity and outcomes. And assessment of reversibility and treatment. Investigating whether meth-associated PAH patients improve after cessation is crucial for treatment decisions and prognosis. And then other strategies to optimize management. So identifying best therapeutic strategies and monitoring approaches will enhance the methamphetamine-associated PAH patient care and improve outcomes. So what are the learning points? Methamphetamine misuse is a significant global issue, impacting both men and women and posing a definite risk for pulmonary arterial hypertension development. Methamphetamine-associated PAH patients tend to be younger, but present with more advanced disease, higher functional class, and lower cardiac index compared to the IPAH counterparts. Female predominance in methamphetamine-associated PAH is still noted similar to other PAH forms, which may be linked to the estrogen paradox. With rising methamphetamine misuse in the US, understanding methamphetamine-associated PAH pathophysiology is critical for prevention and targeted treatment development. Thank you for joining us for this methamphetamine-associated PAH case review module. Please click Continue to complete the brief post-test and evaluation to claim your respective credits for this activity. Thank you.